Therapy for OCD, part of the Vālant Learning Series. Dr. Welch here will start presenting, and we'll have time for question and answer at the end, and we will also be emailing out a link to the recording for this. So if you guys miss anything, we'll be sending that out today. And we're also hosting a live Twitter feed at Vālant, #ERP Therapy, so you can send your questions there as well. And Dr. Welch.
Hello, everyone. Thank you for joining. If you, as you're listening, would mind just typing in what your experience level is with exposure and response prevention for OCD. Experience, you've treated maybe more than 5 to 10 patients, let's say, with ERP, inexperienced, haven't done it at all, or moderate. That would be helpful for me to know, and I'll sort of gauge and modify my comments accordingly. So you can just type that in, right, Natalie?
Yeah.
All right, so I'm Dr. Welch. I started an anxiety disorder-focused practice where I wanted to see about half OCD about 10 years ago, and that practice exploded here in Seattle and became a pretty large anxiety disorders clinic here where we treat the range of anxiety disorders and see 30 to 50% of our patients have OCD, and we serve around about 500 patients a week here now. And we talk a lot in our team about exposure and response prevention. So exposure and response prevention, why we are talking about this today is that among psychotherapies, it is absolutely without question the most effective psychological treatment that we know of, that the data can point us to at this moment for OCD. If you look at studies, I won't take a long time with this data, but in general, you can expect if you're doing exposure and response prevention as a treatment, around 70% of people to improve. And improvement means that we cut symptoms by about 30 to 50%, which, as you know, is a pretty good medication. Recovery, really not having OCD anymore, that's close to 40%. So that's pretty darn good in psychotherapy research. Now, in my clinic, everybody wants to be recovered, and so we work pretty hard over time to get to that. And I can comment on just sort of lengths of treatment and getting people to recovery, what we do if we can't get them there. If that's of interest, just type in that question. Limitations of exposure, just right off the top. Some people don't improve. That 30% figure you can see almost always refers to people who we cannot get to engage in the treatment, which, as you're going to hear in detail, essentially involves doing the thing that you're afraid of if it will not actually hurt you again and again. Very difficult to do. About 25% of patients in our CTs, where treatment is generally free, refuse treatment. In some OCD studies, that number jumps up to as high as 40%, and 20% drop out of treatment. So there's a high refusal and dropout rate. Now, I'll say in my clinic, one of my goals was to find a way to reach OCD patients with this therapy that I knew was very effective. And my goal has always been to have a dropout rate of 5%. And we have gotten pretty close to that, and I'm happy to share tips about why. But in general, this is a hard concept for people. Face your fear again and again is not what people typically want to do when they're presenting to psychotherapy. This webinar really is intended to give you guys a detailed sense of, if you were to do ERP, exactly what would you be doing? So if you do this psychotherapy and you have questions as we go, please type them in. I'm happy to have Natalie help me read specific cases, and I think we email detailed answers for those that we can't get to. If you've not done ERP, or you're someone who collaborates with therapists doing ERP with med management or any other context, I hope you'll find this just a helpful way to envision what should be happening in proper exposure and response prevention. All right, so in general, we would divide ERP into 4 phases. The initial assessment of the patient, which in OCD, there's some specific things that you really want to know to really do a successful ERP treatment, and I'll talk about those in a second. Phase 2 would be building a hierarchy, which guides the treatment. phase 3 would be actually doing the exposure and response prevention, and then there's this relapse prevention and maintenance. In research trials, they're typically 17 to 22 sessions. In my clinic, we see people often in our child and adolescent clinic on and off throughout development. That's common. And often with patients who do the ones who do the very best, sometimes they never come back. A lot of times people check in every couple of years, and we expect and encourage that. Okay, assessment. So, on the data end, for any of you who are particularly interested in the data, my best recommendation is to read John Abramowitz's article. It's back from the 90s, but the title is, Does Exposure and Response Prevention or Behavior Therapy Cure OCD? Best description of the data out there, I think, still. Okay, assessment. So obviously you do a clinical interview, and I just wanted to mention kind of the gold standard measures. The main one is the Y-box. That's the Yale-Brown Obsessive Compulsive, I think, symptom or severity inventory. And that one, I believe we could send out if anyone doesn't have it. It's used in every research study, and OCD therapists, we often talk about the Y-box. So that's one measure that if you have OCD patients, I'd recommend using. The OCI and the DOCS, these are two other measures that are kind of around that can give you subtypes of OCD. I think if you see a lot of OCD patients, they're sort of helpful. But if you've got one, you'd want to use the Y-box. If you are supervising residents, postdocs, I would get a copy of the ADIS-4. That's the Anxiety Disorders Interview Schedule. It's used in all the big research studies on anxiety. And what's great about it is not so much that, but for OCD, people who are learning about OCD symptoms can really rely on this long list of examples of compulsions and obsessions, and it's helpful, I think, if you're learning to rely on that. In general, in your interviews, you want to ask about what cues the OCD. When do people have obsessions? When do they do compulsions? Situations, time of day, people, mood states. These are you want to get a pretty high level of detail about that to plan your treatment. What are they afraid of? We often talk about flavors of OCD, where sometimes people are afraid if they cannot engage in a compulsion, something specific will happen. If I touch the desk and I do not wash my hands afterwards, I could get hepatitis C, and then I could get very sick and die. Other people don't have a specific feared consequence. They have just sort of a feeling of doom or a general vague anxiety that's very punishing, or a vague feeling of disgust or things being not right. So we often talk about this just right flavor of OCD, and that's something that when you interview OCD patients, it's really helpful to know, because a mistake I often see is that therapists focus so much on, well, what are you afraid will happen? The patient says, I don't know, it just feels really wrong. And there's a lot of kind of chasing down a specific when there isn't one. So just something to know about OCD. Rituals, of course, are things that people do to deal with obsessions. Washing hands, checking. Mental rituals are something to know about. This can be something that's sort of obviously OCD, like in Edna Foa's Stop Obsessing book, there's a wonderful and now kind of famous example of a patient who had contamination OCD, was afraid of germs, getting sick and contaminated. When she stopped washing her hands, which was the obvious ritual, she started just picturing pouring Clorox over her skin or picturing Clorox. And this is what we think of as a mental ritual. Now, mental rituals can also be very subtle. They can look like very good cognitive therapy, logic. I must not be contaminated because I didn't touch it that long, or it was my therapist's doorknob, which is probably clean because they wouldn't treat OCD with contaminated doors. Mental reviewing, I must not be gay because there was that time that I was attracted to a man, so the fact that I looked at my best friend and thought she was pretty must not mean anything. These kind of logical processes can serve as rituals and compulsions. And then there's good old avoidance, just not getting around the cue. All of those are really important to detail. So you're going to take sometimes quite a long time. When I first trained in OCD at Emory with Barbara Rothbaum, she suggested to me that I not start my treatment sometimes for several sessions before I really understood the OCD. And when I have had situations where I have the luxury of that time, it's served me very well. Observing and self-monitoring are, of course, good ways to assess, too. This is just a slide that details specific language that you can use. I'm not going to go through this slide in detail because it's just language for everything that we just covered. And if you don't have access to a measure, I thought you might find this useful. I'll just take a minute to let you look at it. Here would be examples of a good mapping out of cues, feared consequences, rituals, and avoidance. Let's go through two examples together. The first one would be a patient who, in the situation of having to touch a faucet in a public bathroom, begins to be afraid that he will contract hepatitis and then die. So really specific feared consequence. You can sometimes find out about thoughts about that. Might be, then my kids will be left alone, or there might be images of being in a grave or actual dying. Rituals would be for this person that he washes his hands excessively, 10, 11, 12 times, and uses hand sanitizer all throughout the day. You often see the hallmark of OCD, these sort of red, raw hands are not infrequent in this population. And then avoidance, avoiding public bathrooms, avoiding ones that look dirty, touching faucets with a paper towel. Of course, we teach this in some hospitals. And that is a pretty good map for ERP treatment. Another situation we'll just go through briefly, holding a knife in the kitchen might create an obsession about stabbing one's daughter, killing her, then going to hell. Ritual might be mental reviewing. I've had my hand on the knife the whole time. She hasn't been in the room. I'm looking at her. She looks fine. And avoidance of using knives. Another really common OCD phenomenon that we see all the time in the clinic. Okay, so these are the assessment issues. Another thing, if you look at that second bullet point, that's nice to ask about if you have time, is how much insight the client has that these symptoms are OCD. Sometimes people will tell you, I know this is these things, and that would be a high level of insight. Other times people will tell you, I think this might be right. I think I might actually die. I think I might actually kill my daughter. I think I might actually go to hell if I squish a spider and kill a living thing. And one's motivation for treatment, it goes without saying, really correlates pretty highly to that level of insight. There's a term in the OCD literature called overvalued ideation, and that's basically somebody who doesn't have much of a sense that this is OCD, not true, and those folks do a little worse in treatment, actually quite a bit worse. Another good thing to look at is the level of significant others' involvement in the OCD. And sometimes with parents and spouses, you can get a lot of mileage by involving those people in treatment. All right, so let's talk a little bit about how to educate people about OCD. So it's good, I think, to go through what are obsessions, what are compulsions. Most clinicians, I think, are pretty good at that, so I'll just move through this slide pretty quickly. This is a model we kind of like, and sometimes with our adult clients, we'll actually use this handout and have people go through it and jot notes about their own symptoms with this handout, where we look at intrusive thoughts, ones that are cued by a situation, and some that just occur. It's a really tough time for many people who have OCD where the thoughts just come unbidden all the time. They trigger anxiety, guilt, and there's often a negative interpretation about the thoughts. Does the fact that I thought about stabbing my daughter and was worried about it mean that I actually want to? What does it mean about me that I'm thinking this? Triggering more anxiety, guilt, and then compulsion and avoidance. So it's kind of, I like going through this at a fair level of detail because my experience is the more patients understand the model, the better they help us plan and implement the treatment. When you're educating about OCD, talking about how obsessions and compulsions relate is really important, such that as one does a ritual like washing hands after touching a faucet, the rituals really strengthen the occurrence of obsessions, such that while it gives that quick relief, one will never learn that the distress could go away, that the obsession isn't true. And rituals, compulsions are really the thing that maintain OCD in our experience. So it's kind of an interesting little fact about OCD that when, 40, 50 years ago, when patients started being put in the hospital and could not wash, a lot of people with washing compulsions started getting better only because their rituals were prevented. That's where the response prevention term in exposure and response prevention really comes up, is that we want to prevent the ritual, and when we can do that, often we see the strength of the OCD plummet. It's really something to see. So some of the OCD programs will actually have pretty hardcore entrance criteria. This is why so many people drop out. For example, if you wash too much, that's your OCD symptom, you might be asked to have no contact with water for a week. Now, if you can do that, you will get anxious. I might be contaminated, I might die, I might get sick. Your anxiety level, you can see on this slide, will go up. If you do a compulsion, of course it makes anxiety go down. But if you can hang in there and not do it, you see a different effect. I'll show you that in a minute. We want to really educate people that if they do not engage in the usual OCD response, they will begin to feel better. Anxiety does come down. It does not remain indefinitely. People don't go crazy when they're really anxious. They might cry and get really upset and be pretty miserable, but they don't go crazy. And the negative consequences, by definition, we're treating anxiety disorders where the fear is excessive, and so those negative consequences are very unlikely to happen, or they don't happen. We have a handout for those of you who would like those materials, just understanding cognitive behavioral therapy. ERP, I should say, is a type of cognitive behavior therapy, sort of a special CBT for OCD, and we're happy to send that to you if you'd like it. What happens, of course, over time, if you can hang in there, not wash those hands, not put that knife away, not go back and check whether you ran over someone, is that anxiety goes down. Now, I wish it were as linear and smooth as this slide suggests that it is. It's bumpy and messy as human beings are, but it does go down. Should we pause for questions or just kind of roll through?
Let me roll through and we'll take a couple minutes.
Great. All right. So that would be the first phase, and that can take a long time or be one session, depending on the patient and your own comfort with OCD, the complexity of the OCD. Hierarchy is the next. So hierarchy is, of course, basically just making a list in order of the cues, reviewing the model and the treatment, developing a SUD scale and a hierarchy. So a SUD scale, this, I can't help but smile. You can't see me, but SUDS makes me laugh a little because it's the subjective units of distress scale, which is basically a fancy psychology phrase. Psychologists are always afraid of not being real scientists, so we use so many fancy sounding scales. It's basically a 0 to 10 scale of distress, anxiety, whatever, or 0 to 100. There's no difference. And this would be an example of just anchors. So you teach the patient a rating scale, make sure they can rate their anxiety or distress. And then a hierarchy is essentially an ordered list where you'd include on it situations, thoughts, and images, about 10 to 20 items with info from your assessment, cues, obsessions, and just have the patient rate, assuming that they did not ritualize, how anxious would you feel if you walked in a public bathroom and didn't wash your hands? Maybe the patient would rate that a 40. You might ask them, how anxious would you be if you actually used a bathroom and didn't wash your hands? That might be a 90. How anxious would you be if you imagined going in a public bathroom and not washing your hands? Maybe that's a 20. You're essentially rating all kinds of different examples, and the hierarchy becomes your guide for treatment. It's pretty simple, actually. Here's an example of a patient who had obsessions about hitting and killing a pedestrian. This is a common one. I would guess many of you have seen it, where people will go back after driving and check to make sure they didn't hit someone because they had the image or thought that they did. And another one, leaving the stove on, so checking the stove, and house burning down. These would be both checking compulsions, checking subtype. So the hierarchy might look like this. At the high end, driving downtown, lots of pedestrians at night, where this patient is going to be really concerned that she might hit someone and not realize it. Down to the low end, just driving in one's neighborhood, 35, not so bad. Reversing in a car in the middle, if you go up to that 70, might be reversing in the car with the radio on. The radio, of course, would be distracting, making you more likely to hit someone without realizing it. You can see one other note about this, just for any of you who are new to these hierarchies. You do have the same situation often on these lists with multiple kind of variations, like driving on the highway in the day, driving on the highway in the night. And those are helpful because when you do exposure, it's hard to do, and the more varied situations you can have where you'll send the patient out with a very specific idea of what they are going to do, the more you have, the better. Okay, so once you're done with your hierarchy, which again could be very fast, it could be done in one session or it might take many, you would move on to the actual exposure and response prevention. All right, exposure, of course, is when we elicit on purpose the thing that is feared. We only elicit things that are not actually dangerous. So in OCD, that's usually pretty easy. In OCD, you know, obsessions are often a little, they're a little extreme, like hitting the pedestrian. People will usually say, obviously I didn't hit a pedestrian, or they'll be afraid that they accidentally threw out a baby in the trash, for example. Oftentimes, it's obvious to the patient and to you that that's not going to happen. One thing I just want to say, because it's a question that sometimes comes up with the topic of exposure in general, and I think one question before the webinar asked this: what about exposure to things that might be happening, like loneliness? In that situation, you would really want to assess, is the thing that's feared actually happening? And if it is happening, is it dangerous to the person? Loneliness, for example, that's not an OCD symptom, but loneliness would be something that most humans are going to find very painful. It won't kill you, but you don't really want it. And you might or might not do exposure to something like that. With OCD, you're going to elicit the feared cue, the faucet, the doorknob, the image, and you want to start with something on your hierarchy, on your list, that is rated at around a 30 or 40 of difficulty. Really important, again, to make sure that rating is assuming the patient did not do the compulsion. Really, really important. You want to then bring that situation to life, ideally for the first one in the office. A lot of people will do ERP by saying, okay, well, how hard would it be for you to go home and prepare a meal? Let's say the patient had obsessive fears about how food was prepared and didn't want to eat any food that they didn't prepare themselves. And we said, all right, how about you get something from the drive-thru, go home and eat it. And then don't look at the ingredient list or, check your symptoms 20 times that night. A lot of people will send patients out to do that. I kind of want to make a pitch to everyone and just recommend that if you possibly can, you want to do as many exposures in your office as you can, especially that first one, so that you can coach and help and just learn what someone's brain does. I think it also, in my clinic, we emphasize that so much because some of the data on OCD are really clear that if you do exposure with the patient together, your outcomes are just a lot better, quite a lot better. So assuming you did something in your office, you got, I don't know, Taco Bell or something and started eating it there with the patient in your office, you would then ask them how distressing it is about every 5 minutes. it's often a question like, well, what do you do? There you are touching the floor or, licking your shoe or whatever you're doing. What do? You kind of hang out with the fear. You encourage the patient to focus on it. And then you rate SUDs. I usually just jot down on a piece of paper where they are about every 5 minutes. You want to expose the whole time. Some old, and by old, it's really early 90s I'm referring to, some older tapes on exposure and response prevention shows a therapist giving the patient a cue and then distracting them. So there's a famous tape where I think the patient touches a scarf that she thinks is contaminated. One, there's a dead mouse or something. And then the therapist engages the patient in a relaxation technique or a topic that they'd find distracting. We don't do that anymore. Same with breathing. It's better to just focus on the anxiety, what their body feels, what they're thinking about, what's the image, what are the thoughts about what's happening, the germs on the body, really focusing on it. Make sure they're not ritualizing on accident. This is why we spent so much time in the beginning on education, because when the patient knows what a ritual is, they will often point it out to you and say, God, I didn't realize it, but actually I was just reassuring myself that this isn't really an exposure because you're here. What do I do? Then we want to add that to the exposure. So I'll often say, okay, tell yourself that's just a reassurance thought. You're really contaminated. You want to really contaminate the whole body, full exposure, leave enough time, do them with the client, and focus on the feared consequence as much as you can. Now, one thing that can go wrong is you go in, you've got this great plan, you think it's a 30 out of 100, there you are, you've got I'll use a funny example. Our psychiatrist a couple of years ago went down to our parking lot, had a patient who was worried about running people over, bump into him with his car, which is a very funny and kind of extreme thing that we were all a little shocked by, I have to say, on my team. Now, you could do something like that, or less extreme, and find that, wow, that wasn't a 30 out of 100, that goes to a 90. What do you do then? Well, then you can distract, you can change the cue, you can talk about something else. You don't have to stick with a 90 when you tried to get a 30. So, there are exceptions to every rule, but in general, you want to focus on that fear. All right. Assuming your exposure goes well, what you should expect is that people get afraid, they get distressed, and if they stick with it, they start to get less distressed and less afraid. And I will say, as a person that really loves working with these patients, it is one of the most miraculous things. I don't know if I will ever habituate to it. It's incredible to see someone experience that before my eyes. And when that happens, when someone's anxiety decreases while they are with the thing they were so afraid of, lessons are learned about how much the consequence happens, how much they can tolerate their own anxiety, their own power as a human being. It's pretty amazing. Sometimes it doesn't seem to work, and I just want to go right to that because it's probably the reason many of us are kind of nervous to do exposure. What if anxiety doesn't decrease? You've done it all right, there you are, it's 15 minutes to the hour, and the patient is still freaked out. What do you think about doing? The first issue is it's really, I almost hate to say it, but it's true 9 out of 10 times. It's just the dose. Fear takes a long time to build up, and if you think about the budget and advertising campaign of the OCD, those compulsions have been done so many times that sometimes it just takes a while for exposure to work. So a lot of those research studies, I am going to tell you this now, I didn't tell you this before, those sessions are 2-hour sessions many times. So we can't all do that in practice. But knowing that the dose sometimes needs to be high is good because you can plan with the patient, you can pace yourself, and give them kind of a sense of appropriate expectations. So I'd say almost always dose. Sometimes they are ritualizing or distracting themselves, and so you're kind of doing the exposure on the surface, but not really. And so just talking with patients about that possibility, if it doesn't seem like exposure is working, you just explain to them that this can get in the way and see what they think. They usually can spot it with you. Sometimes you don't have the right cue, or the cue is just too hard. So we start with 30s because it's enough fear to feel, but it can go down in a reasonable amount of time. And 90, boy, it's just can be a real slog, so it can get discouraging. The other thing that's not on this slide that can happen is that someone really believes that the feared outcome is happening. That sort of cognitive experience can make exposure not work so well. So you can kind of assess for that and work with patients on that. This is in vivo exposure. Sorry to go back to that slide. In vivo just is the term for live exposure. Exposure to the cue live, the dog, the knife, holding your breath, driving your car. Imaginal exposure, if you go to the next slide, that's just exposing to a thought, an image, something in one's imagination. And we use that when we need to prep for in vivo. Someone's not ready to touch something, we imagine touching it. Sometimes we want to imagine a consequence that won't actually happen. It's a common OCD-ish thought, and many new parents have it actually. What if I stab my baby? Now, assuming one is not going to stab their baby, and this is just an obsessive thought, that thought itself is not dangerous, and you can do exposure to it. The thought, I might stab the person, the sentence. The image, I might stab the baby. Which one would you expose to? You'd expose to whatever is in the person's mind and bothering them already. You don't make up content because then you can introduce fear when you don't need to. Consequences about the distant future going to hell, you might use as exposure, and you're obviously going to imagine that, not try to act it out. Spontaneous obsessions, not triggered by an identifiable situation. Sometimes in OCD, patients will have rhymes in their head, words, images, counting that just pops out of nowhere, and you just have to expose to that. And the last thing is, this is really the latest of the late, the most current research and clinical thinking about OCD. If you do a live exposure and you combine it with imagination, your outcomes will be better. Here's what I mean by that. If you have someone who is afraid of driving their car at night, let's use that example, because they're afraid they could run over a pedestrian, and while they are driving, they think to themselves on purpose, I could run over someone. I could have run over someone. That is in vivo combined with imaginal exposure. That's actually what happens to people. They're in a situation and their minds are active. They think, they imagine. If we can replicate that in our treatment, it goes faster, it goes better, and it's more complete. The rationale with this is kind of like scary movies. You know, most of you probably watched a movie that the first time was terrifying, and the 15th time you watched it, you know what's going to happen. It no longer scares you. Mental images and thoughts are the same. So when we're doing imaginal exposure, sometimes it's just brief phrases and sentences. Other times it's an anxiety-provoking story, like a 1 to 5 minute story that we repeat. Often now it's on people's phones. We put it on a smartphone, record it, and then they just listen to it over and over. And what happens is something that creates a tremendous amount of anxiety at first becomes kind of boring. And then our treatment, then our work is done. You want to know whether people are thinking about catastrophic consequences, like I killed this person, versus an uncertain outcome. I'm not sure whether I killed her. Maybe the fact that I thought about this means I could have killed her. That's important to know. That's back to assessment. And you repeat whatever is relevant for the person in the exposure. I would not recommend including elements that lead to strong depressive feelings, like being alone for the rest of one's life. The thoughts and feelings that trigger anxiety are very effective in exposure scripts or these sort of imaginal exposures. Thoughts that lead to sadness and depression do not respond as well, as far as we know right now, to exposure. So if someone writes a little story and at the end they say, God, I'm so down and sad, I change the script. You want it to be as real as possible, present tense, include thoughts, physical reactions, and behaviors, no ritualizing in the story. Otherwise, what will happen? They will accidentally strengthen their OCD. And if people often ask, should the patient read it? Should the therapist read it? It doesn't really matter. It's kind of up to the patient. But if you read it, you want to read it with a little emotion. So it's not like a relaxation script or a hypnosis script. Here's an example. If you want, just lean back and imagine it. We'll send this to you or any other ones you want. Just try to imagine this. Here's an example. The fear is of hitting and killing someone while driving again, so we can flesh this out. You and a group of colleagues are traveling to a conference in New York City. The group of you decided to rent a van to drive to the hotel from the airport. When you arrive in New York City, your colleagues ask you to drive because all of them had too much to drink on the plane. You don't anticipate them asking you to drive, and so this request comes as a surprise. When they ask you to drive, you can feel your stomach drop. You are worried about having to drive at night in a car that is unfamiliar to you. You're generally worried about driving, and this is one of the worst possible situations for you. New car, new city, and a car filled with colleagues. You try to convince them that you shouldn't drive, but it's useless. None of them can drive. You're transferred to a car rental office and receive your car. Of all the possible cars, you get one that's small and has a small rear view window. You think to yourself, this is unbelievable. Of all the possible cars, I get this one. Everyone piles in the car and you begin driving. Problem is that everyone is talking a lot. After all, they're intoxicated. It is therefore really hard for you to pay attention. You're driving on the highway and it's late at night. As you drive, you realize that you can barely see out the back window. It is also snowing out, and for some reason, traffic is bad. The roads on the way to New York City are bad. You constantly hit potholes, and each time you wonder whether you've hit someone. Now, during this script, I'm just going to pause. We would have rated, I'd probably have the patient just pay attention to their anxiety, and I'd expect little spikes like right here. I'd probably read the whole thing and have them rate or tell me the first time we read it, or that they wrote this, where the spikes of anxiety are. This is a longer script. Sometimes it could be maybe 5 sentences. Should we keep reading this, Natalie, so people can imagine it?
Yeah.
Let's keep going just so you can get the experience. And if you have this fear, you should be anxious. If you don't, you probably are not very anxious. Let's see. You constantly hit potholes. You wonder, how can you be sure that you didn't cut someone off? After all, your back window is largely obstructed. Each time you change lanes or hit a speed bump, you become mortified. You're sweating profusely, and in your mind, the bodies are piling up. The situation becomes even worse when you arrive in downtown New York City. There are people everywhere. This is a scene that you are unaccustomed to seeing in Seattle. Traffic is so heavy that you're inching along. As is customary in New York City, people are jaywalking everywhere. This fact, coupled with even more potholes, increases your anxiety even more. You feel like you are about to pass out, and your stomach is in knots. You have images of hitting several people, and now you are sure that you are going to jail. You finally arrive at your destination. On the one hand, you are happy to have arrived, no more driving, but that doesn't erase the fact that you've probably killed several people along the way. You have difficulty sleeping, but eventually forget about what may have happened. You don't hear anything on the news, so you probably didn't hit anyone. However, your fears are confirmed when shortly after arriving home in Seattle, the police show up at your house. They ask you a series of questions that suggest that they think you killed several people. You're eventually charged and placed on trial. The case is highly publicized. You're convicted of 5 counts of manslaughter and sentenced to 40 years in jail. You ultimately die in prison. Now, this script, a good question would be, why would you put in the jail business, the manslaughter business? You would only put that in this script if that was what the person was obsessing about, was thinking about. If they didn't occur to them, that would not be in the script. So the exposure is really to what they'd already thought about. After exposure, you're going to really emphasize homework. I hate to say it because it's so hard for people to do, but they really do have to practice. If they don't, therapy just, sometimes it doesn't work, sometimes it just takes longer. It depends on the patient. You want to have them record their anxiety. No magic to this. It's just making sure they're doing the exposures at home or imagining and kind of recording what happens so that you and the patient can work together to make sure you've got the exposure and the dose right. Here's a tip. You'll see a lot of contamination fears or fears about a certain object. And exposure works the best when you have a sort of constant level of exposure. The more the better. So one tip is to take a cloth or a Band-Aid or, whatever you can get and just get the contamination germs or the germs from the image, whatever it is. OCD is a disorder where there's a lot of contamination emphasis. Get those germs on everything in the house or on the cloth or on the Band-Aid and have the patient wear the Band-Aid all the time. These little sort of creative tricks, and you'll think of many, are some of the things that makes the treatment really fun and also really effective to just see how can I get this dose higher without driving the patient crazy. Key exposure issues, again, combining that imagination, what happens in your mind and what people are doing with their bodies is really good. Homework is a big deal. We go gradually up the hierarchy. The pace, as fast as you can go without overwhelming the patient. You have to repeat exposures as a general rule. You have to get the dose right. Again, it has to be long enough so that anxiety can actually decrease. You want to make sure you're doing exposure to the feared situation, the obsessional thought itself, and the feared consequence, whether that's a feeling or an actual idea of something that could happen. No ritualizing when you're doing exposure. And if you somebody actually accidentally ritualizes, you re-expose or undo it. Here's an example. Let's say the person, let's keep with our car example. They're afraid they hit someone. They can ritualize by mentally reviewing the road and everything that they saw on the road. Or some people now can record the view of the little car camera of the road, and they could watch that over and over. But more likely in their own mind, logic, mental reviewing. If someone accidentally does that, you would say just undo it. Say, I could be mistaken. That's just my mind. It probably happened. Maybe it did happen. It's pretty easy to spike anxiety again because of the nature of OCD. That's the rule. In terms of how complete response prevention is, so I mentioned earlier this idea of no contact with water. That's a pretty intense exposure paradigm, and we don't do that in my clinic because we're outpatient and we'd have people wouldn't do it in general. So what we say is you have to do response prevention. You have to stop ritualizing, prevent that usual response for the things that you're working on exposure to. So if you're exposing to opening a door, touching doorknobs, you can't wash your hands after you touch doorknobs. But you might not be ready to shake the hand of a homeless person yet without washing your hands, let's say, common hierarchy item. So what do you do if you shake hands with a homeless person and then you go wash your hands? Well, now you've washed off those germs and the doorknob germs. That's why you want to have a little cloth or a little something that has the doorknob germs on it. It sounds kind of wacky, but you want to immediately recontaminate with that cue so you have a constant level of exposure. It just takes a lot of creativity, I think. I think we've kind of reviewed this, so I'll just leave this up for a moment just to emphasize the point that we're trying to drop as many rituals as possible. We really want to stop them if we can. Usually we start response prevention before we start exposure. That's something that often people don't quite realize, and I think it's because the literature on OCD has not always clarified that enough. Where we'll try to drop some compulsions so that we don't just start exposure and have someone doing more compulsions, and we really strengthen the OCD. Here's just a little example. Always moving into anxiety. This would be an example where the therapist and the client developed rules or guidelines for response prevention or ritual prevention. For contamination, they had minimal contact with water, showering 15 minutes every second day. for checking the oven, stove, coffee pot, a normal glance, let's say. These are just sort of rules people create. Often you talk with the patient about what do normal people do, people without OCD, not normal, but you know what I mean. And then, if they ritualize, just re-expose to the situation. All right, that's the basic chunk of this talk. And I'm going to wrap up just briefly by mentioning that you want to keep relapse prevention in mind. OCD is a chronic condition. And so when someone's ending treatment, it's good to just really think about how they'll handle it in the future. These are just some general guidelines that I think are pretty maybe self-explanatory with most conditions that we treat. Just a quick word, and this will be the end of this webinar, about potential challenges and strategies. So one of the main things you find with OCD is that people are really ambivalent about treatment, that overvalued ideation. It's hard to do this treatment. A lot of people draw a line in the sand. I'll do exposure to this level, but I will not do it past this level. If you've been trained in motivational interviewing, that is so helpful, and there's some research with using that with patients with anxiety disorders. We really think that helps. Slow it down. Making sure meds are optimized is really important. Often meds for OCD have to be, as many of you know, at higher doses than the other anxiety disorders. And intensive treatment is another thing that I want you to know about. The standard outpatient treatments work pretty well, but there are intensive outpatient treatment where you go for maybe 2 weeks or a month and do treatment every day. And then there's inpatient. If you send someone to inpatient, I would recommend looking up a specific OCD inpatient program. There are some really good ones across the country. And if someone is really stuck, those can be really quite miraculous. And then these are just ideas about exposure. Longer exposures, again, are often needed. It can be a problem that people don't get anxious, and that's sort of a fun problem to have, but you have to solve it or they're not going to get better. So that's just that creative problem solving about what the right cue is. Families are so helpful to weave in. Really do meet with them. Child and adolescent people do that kind of by default. Some folks trained in working with adults wouldn't necessarily do that. With OCD patients, I really recommend meeting with the families if the patient will let you, and just looking for that subtle avoidance. OCD is so sneaky, so it can really help for patients to help you look for avoidance. All right, so thank you all.
Thank you for joining us. Thank you, Dr. Welch. Just a quick word about Vālant, who brought the webinar. It's Behavioral Health EMR and e-billing suite. I'm in charge of sponsoring these webinars with the Therapist Practical Findings series. And I'm just going to launch a quick poll to see if you guys would just take a minute and answer. If you are interested in learning more about Vālant, you can answer yes or no on the screen, or you can email us later about it. And then we will get to questions here. And if so, you can type them into the chat box, or tweet questions to @Vālant, #ERPtherapy. And it looks like we did get a couple questions here, so let's just see. It was people letting us know about experience. So based on, if you guys have any questions about the forms Dr. Welch mentioned, you can email us, or you can also call the front desk, Dr. Welch's practice. The number's on the screen. And let us know. We can get you more information. Thanks so much. Thanks, Dr. Welch.
Thank you.